This month is February, Black History Month, as you all know. And in honor of that, we're going to be talking about health equity. And we are honored to have Dr. Evelyn Lewis join us today to give us a presentation on health equity. So I will introduce Dr. Lewis in just a minute. Before I do that, I just want to remind everyone, for those of you who are FAAFP member, you can get CME credit for today's talk, and I sent out information on how to claim credit for that. And please also complete evaluation after the presentation is done. So as we get started here, you can put questions in the chat box. I will be monitoring the chat box. We can give Dr. Lewis time to present and then ask questions at the end. So please put your questions in the chat box. So I'm gonna introduce Dr. Lewis here. Dr. Lewis earned her medical degree from the University of Health Sciences, Chicago Medical School, and did residency in family medicine at the Naval Hospital, Jacksonville. She completed faculty development fellowship at Madigan Army Medical Center and Pacific Lutheran University, and earned a master's degree in social and behavioral sciences. In June 2003, Dr. Lewis retired from the Navy after 25 years of service. After that, for 7 years, Dr. Lewis was Director of Medical Policy, Worldwide Public Affairs and Policy for Pfizer, Inc. Currently, she's a Chief Medical Officer for Warrior Centric Health, President and Chair, Veteran Health and Wellness Foundation, Adjunct Associate Professor in the Department of Family and Community Health at Rutgers Robert Wood Johnson's Medical School, Clinical Instructor at Rosalind Franklin University of Medicine and Science, and appointee to the Department of Veteran Affairs Advisory Committee on Disability Compensation, engagement panel member, Department of Veteran Affairs, Health Services Research and Development, Pain Opioid Consortia of Research, and serves as the American Academy of Family Physicians delegate to the American Medical Association House of Delegates. Dr. Lewis is nationally recognized for her expertise in the areas of community outreach, engagement, and enablement, public-private partnerships, veteran health and healthcare issues, content program development and evaluation, cultural competency, health and healthcare disabilities, women's health, health impact of military services on veterans and their families, PTSD, TBI in clinical trials, minority participation. She is a fellow of National Association of Corporate Directors and American Academy of Family Physicians. And her most recent awards include the RFUMS 2018 Distinguished Alumnus Award and a State of Maryland House of Representatives proclamation. So thank you, Dr. Lewis. I will hand it over to you now.
Well, good afternoon, everyone. Can you hear me okay?
Yes, we can hear you.
Great, thank you very much. Thank you, Winnie, for the invitation to join you all during this time to present to you on health equity. It's a very interesting topic and dynamic in many ways in that it is forever changing for a number of different reasons. And I think we'll see some of that as we begin to go through this process this morning. So I titled this Health Equity, Absent on the Front Lines and in the Rank and File. And I went back and forth a bit with the title, if you will, because I wanted to make sure that as I talked about health equity, it was applicable both to those who were in uniform and out of uniform, and who were providing healthcare to those who were service members, veterans, and to their family members. I have nothing to disclose in regard to what we'll be talking about this morning. And so the objectives that I hope that we can accomplish in our time together this morning revolve around describing the difference between certain terms, and in particular, health disparity, healthcare disparity, health equity, health equality, and health equity. Many times these terms are interchanged with each other, but they do have very different meanings. Secondly, we'd like to identify the contribution of what most of us have come to know as the social determinants of health, and what their contributions are to the issues that surround health inequities. And then to recognize the value of the intersectionality in mitigating poor health outcomes when we speak of, again, these terms of health disparity, healthcare disparity, health equality, and health equity. Oops, wrong way there. Okay. So again, that first objective is to describe the difference between the various terms. And as we think about health disparity, it is a term that refers to a group of people that have a higher burden of illness, ability, and even mortality people are experiencing. And that will become more clear as we sort of work our way through this process in regard to talking about this issue. It is also the difference that affects a person's ability to achieve their best level of health. And some of those examples of health disparities include things like race and gender, education, income, et cetera. And again, we'll talk more about those in a little bit more detail. When we look at health care disparity, it is that term that typically refers to differences between groups in their ability to obtain health, like with things such as health insurance and coverage, access to care, use of that care, and then the quality of the care. We'll see also as we talk a little bit more about this, that having access to care doesn't necessarily get you to a point of having health. And that even is for people in uniform and for those who have served. Health equality means everyone has the same opportunity to be healthy. And we often can recognize that there are many limitations to that. And an example of health equality might be if a community center was offering, say, free or low cost examinations for everyone. That's equality because everyone has access to that same sort of product. This is sort of a picture, if you will, of health equality. You see here 4 different people and you see 4 bicycles. Equality is giving each of them the same bicycle. So you see the young lady in the wheelchair, you see a gentleman who appears to be very tall, an average size female, and a child. And it's obvious that the same size bicycle does not work for each of them, but they have been given equal tools or equipment. Health equity, on the other hand, means that everyone has a fair and just opportunity. And keep in mind the word just, because that is the word that primarily distinguishes health equity from health equality. It's just, it's social justice. You'll hear those 2 terms quite a bit as you talk about health equity. And that's that just opportunity to be equally healthy. It requires removing obstacles like poverty and discrimination. And so there are consequences like powerlessness and lack of access to good jobs with obviously fair and equal pay, quality education, those kinds of things. And this is a picture that depicts health equity, where you see these same 4 people, but you see they have different sized bicycles now that fit them each better. The woman with the paralysis has a bicycle that you can pedal with your hands. The gentleman has a much larger bike, the woman a smaller one, and the child one that suits a child. And this is simply those 2 pictures together so that you can really get a good take on what that looks like. So the next step we wanted to go to was that of identifying the contribution of social determinants of health to health inequities. And so if we think about social determinants of health, so that we'll all be on the same page, if you will, there are these issues that contribute to the social determinants of health. They're grouped, if you will: economic environment. Most people account or set a percentage of 40% to that. Individual behavior at 30%, clinical care at 20%, and physical environment at 10. The clinical care item is oftentimes split, and it talks about biologic or genetic contributions to the social determinants of health. And so each of those, when that one is included, will get 10%. But primarily, the vast majority of the models of social determinants of health will include clinical care at 20%. And that's really the piece that most impacts us, those who provide care to, whether they're veterans, active duty members, their family members, or civilians. That's the piece that we can most directly impact, is the clinical care that's provided to them. This is just another depiction of those factors that determine social determinants of health. And you can see right at the top there where it says genes and biology is at 10%. Medical care after physical environment is at 10%. And I just wanted to show you that again so that you could see a different model and how that factor is often included. So as we begin to talk about how this issue of health equity, social determinants of health, et cetera, impacts health, let's get a snapshot of what the veteran community actually looks like. And realizing that most of you, if you're at USUS, you primarily will see active duty members, but there are some veterans mixed in there. But once you leave USUS, if you go into private practice, you will be seeing far more veterans and a few active duty also. As we know, they sometimes elect to go out into the civilian sector depending on what the issues regarding their health is. So if we look at the veteran community, there are some 18 to 20 million veterans, depending on whose numbers you used and how they calculated that. Of those 20 million veterans, 9 are registered with the VA. And of the 9 million who are registered, 6 million get some care there. It might only be one episode that year, but about 6 million will get some care there. And out of that 6 million, the vast majority of them are male, as are the vast majority of veterans. However, those females that do get their care there, 21% of them get all of their care there. And of the males who gets the care at the VA, 12% of them get all of their care at the VA. And there are a number of different reasons for that. And this slide here talks about some of those variables. It's from 2015, but as you can see, it hasn't really changed very much. When we look at service-connected disabilities, you see that female veterans are higher there. They're higher in terms of their use to the VA, which I talked about a few minutes ago. When you look at no health insurance, no income, and poverty, you see that females outstrip males to certain degrees. And that is why there's a higher percentage of females who will get all of their care through the VA, is because of those other factors that you see there. No health insurance coverage, no income, or that they're living in poverty. And you'll also see that females have a higher percentage of service-connected disability, which is another reason that sort of leads them to getting a great deal more of their care at the VA. And that's in spite of the VA not being, shall we say, outfitted to provide the type of care that many females need in the environment that's suitable for them. So it gets back to that issue of access to care that I mentioned earlier. You often have to ask yourself, access to what kind of care when you're thinking about that. Additional snapshots of the veteran community. We know that the overwhelming majority are white males. Over 4 million have a service-connected disability rating. When you think about females, that group or subgroup of veterans is more racially and ethnically diverse, as it is in the active duty side also. Female veterans are the fastest growing military subpopulation at the time. Right now, we have about 16% on the active duty side and about 9% veterans. The largest cohort of veterans today are those from the Gulf War era. That was up until, I think about 2-3 years ago, the largest cohort of veterans was from the Vietnam War. But as you know, we lose substantial numbers of veterans every day to suicide, and then over the course of the year to other illness, injuries, and diseases. About 11% of veterans are homeless. About 45% of them are African American or Latinx. And about 40,000 are homeless on any given day or night. They use the VA, and it differs from those who don't use the VA. In other words, you saw in the previous graph where there were the veterans who were living in poverty, who had no job, who had no insurance, et cetera, utilized the VA more so than other veterans. And that becomes important because when we look at certain studies that talk about veterans and veterans' health, the vast majority of those reports come from the veteran hospitals, from the VA. And the veterans that are seen at the VA or hospitalized in their facilities are often much sicker than those who are seen out in the general community. And so we have to sort of take that with a grain of salt in terms of how that is calculated and what it actually means. And then again, the suicide risk, as we all know, is much higher for veterans than it is for their non-veteran counterparts. When I'm speaking more to the civilian sector, I often utilize this, which was created by a nurse practitioner, PhD colleague of mine in New York, as he began working with more of the civilian sector around identifying and how to better work with and assess the needs of veteran patients or their family members. And so he developed this mnemonic to help them through that process. It's often a process I talk with about to other civilian hospitals and providers, again, when talking about the topic of veteran health, because oftentimes a lot of this is missed. And most of it is missed because they neglect to ask one simple question, and that is, are you a veteran and have you served? I often mention to colleagues when I'm giving this presentation or a presentation similar to this, that I retired in 2003, and not one physician to date has ever asked me, am I a veteran or have I served? And so they don't have any inclination to understand or begin to suspect whether or not what you are there for is either a result of or an associated with your service. This is this graph right here represents a study that was done by the RAND Corporation, and it talked about provider readiness and it failing veterans in terms of providing them adequate care. So this was done in New York City, and it was done, I think a couple of years or so ago, I think 2018, 2017, around there. And they devised a list of things that providers needed to be able to do. And as they went through that list and assessed the providers that were part of this study, you can see their readiness to provide services to veterans, et cetera, went from 92% to 2%. It started out with accepting new patients, using clinical practice guidelines, screening for common conditions. And then it gets to, when you get to the single digits, you see it gets to the pieces that are very important to this population of people, and that is familiar with military culture and screens patients for military affiliation. A question I just mentioned a few minutes ago that I'd never been asked by any of my civilian providers. And so one might think, well, this has nothing to do with us because we're in uniform, we're taking care of people in uniform, or we're taking care of veterans. Those are the only people who are in our clinics for the most part. So we don't have to ask that question. And that's true. You don't have to ask those particular questions, but there are some questions that you may need to consider that I can also say I was never asked when seen for a particular appointment or ailment or illness or injury, because I think a lot of times we just assume that because we were there, we were in uniform, our patients were in uniform, and so we assumed we knew a lot, whereas a question or two might have helped direct us a little bit better. So now we sort of know what that veteran community is like in terms of the folks that we're talking about in regard to health equity or inequity. And so now we're going to look at how all of those things sort of come together in terms of uh, mitigating poor health outcomes. And this is where I'll talk about some of our folks who are still in uniform, as well as the veteran population. So if we were to think of the war era in chronic conditions, like the number of chronic conditions that veterans typically have, when we look at World War II, most of those who came back in transition from active duty to veteran typically had about 2 to 3 chronic conditions. In Vietnam, it was 4. Global War on Terror era, it was 8 to 9. And when you overlay that with multiple deployments, you see that number jumps exponentially to 11 to 12. And so those chronic conditions oftentimes will multiply the various complaints and ailments that the veterans will present with. And again, if someone is not tuned in to both the culture of the military and the veterans, as well as the era in which they fought, they will overlook or could potentially overlook a lot of information that could be very helpful in terms of determining what exactly might be going on, or what types of studies, tests, et cetera, they need to order to expedite getting to the diagnosis in order to hopefully have a better outcome for that patient. Chronic illnesses of veterans, again, some of the conditions of the military service we all know are debilitating, and a lot of that is a result of where we do our jobs and what types of jobs we have to do, whether that's in a combat setting, where we're exposed to toxins, et cetera. Iraq and Afghanistan, where we're hearing quite a bit about burn pits and their exposure. And many people are starting to ask that question: how is it that we take the healthiest of the healthiest and put them in this end, and when they come out on the other end, there are those people with 3 or 4 or 5 or 6 chronic conditions. Then we look at multiple deployments and improved battlefield medicine. And what that says to us is that we have more people now who survive. I remember speaking specifically about 17, 18, 19-year-olds who were going into Iraq and Afghanistan, and why we needed to pay more attention to them coming back and better understand military culture, et cetera, as well as what adolescence is, and sort of weaving those two together. And one of the nurses asked, well, why is it so important? Because we've always sent the young people to war, 17, 18, 19, 20-year-olds to war, because they're healthy, they're able to do the type of work that needs to be done. I say the difference now is if they are severely injured, they come home because we have the capacity to save them now. And I certainly don't need to speak in any significant terms about that, because of where the vast majority of you are located at USU, near Walter Reed, et cetera. You see that every day. You see the representation of young men and women who have been seriously injured and disfigured as a result of their service in those environments. And then, of course, the families. We often say military service members and veterans. When I use those two terms, I always mean to include their families, because they too obviously can become unhealthy relative to the general population because of what their spouses did, and partners, et cetera. So we talked a little bit about chronic illnesses and the numbers of them that they could come out with. But when you look at this, because when we talk about chronic illnesses and we talk about war, theater, et cetera, we often think that people must be deployed in order to have those kinds of illnesses, diseases, and injuries. And that's not necessarily true. When you look at this slide here, you can see deployed versus non-deployed. And while those who were deployed had a higher incidence of these diseases and injuries, you can also see that those who were not deployed had many of the same diseases and illnesses. And so we also have to keep that in mind. And again, that comes in sort of gaining that history from someone, because if you think the only folks that would have encountered Gulf War illness would have been those that were deployed. But as we can see from this slide here, that may not necessarily be the case. So as we talk about inequities, there are a lot of different definitions or statements, shall I say, from a lot of different entities who deal with health and health inequities. And so I looked at a number of them, and I thought this one from the Public Health Institute in Massachusetts was very fitting for the path that we were going to follow here as I was talking with you today. And so their health equity statement reads as you see here: a historic legacy of social, economic, and environmental inequities such as racism and gender-based discrimination are embedded in societal institutions and result in poor health. These unjust inequities affect communities differently, with some bearing a greater burden of poor health. These inequities can influence health more than individual choices or access to health care. And part of the reason why I chose to use this one is because it speaks to a lot of what we've talked about so far, and definitely some of what we're going to talk about going forward here. Because we did talk about access to healthcare, but you also heard me talk about access to what kind of healthcare, what was on the other side there. Just because you can go in and see a provider doesn't mean that you're going to get what you need. So as we look at female veterans as sort of a subcategory of veterans in general, you can see that the government has recognized the need for gender-specific personal protective equipment since 1978. Dakowitz first addressed the issue back then. And it was in regard to poorly fitting protective equipment. And it wasn't just uncomfortable, it fit in a way that it actually prohibited or made it difficult for them to do their jobs. Improvements have been made over the years, as you see stated here, and it's helped reduce some of the risk of musculoskeletal and overuse injuries, but not to a significant degree. And then, as you can see, most service women are still unable to access the equipment for training or deployment that's needed and that fits them well. Designing military systems for females in combat. It's also critical that females are fully considered as we look to design new equipment and new systems that prevent adverse health effects, obviously when operating in a wartime environment or in a training environment, as far as that goes. And in trying to ensure that that equipment doesn't prohibit them or make it dangerous for them to try to perform their job. As you can see in this second bullet, talks about the inability to physically reach controls within equipment that they will have to use was one of the most commonly occurring design-related issues that affected the women and indeed some men also, but primarily females. Again, as we look a little bit more and talk about this design military systems for females in combat, and remember this started back in 1978. So you could say it's finally changing this year. The article's headlines state, finally. The only problem is this has been finally changing for years. And you can see from 2011 to 2020, we're now in 2021, women in combat were armor designed for men. This is 2020, the last line there. That's finally changing, and we're still there. It's coming. They're closer, much closer to it now than they have been. But the mere fact of having women in this environment and not having them adequately protected speaks volumes to, again, some of these inequities that will result in problems that they will have that their male counterparts may not have. And the fact is, do we ask about that? Do we concern ourselves with, is this the reason for this musculoskeletal injury? Is this the reason that they will end up being one of those who has a significant service-connected disability as a result of what is happening now. When we begin to talk about another subset of veterans and look at African Americans, I thought this article that was published by, I believe it was CNN, but it was around an interview with David Shulkin, while he talked about active duty members, actually, and then we then transitioned from that to the veteran population. But you can see here, he says, while there's been some increase in relative numbers in minority officers, it's not been proportional to the increase that we're serving. So therefore, you have more minority members serving in the frontline jobs and therefore getting higher numbers of the injuries. And that was something he said to CNN on the Friday of that interview. And what that says to us is, again, when we talk about inequities and how people have more of this type of disease and that type of disease, what prohibits them from getting the best health that they can. When you look at the numbers of African Americans who are in the general population, those who then join the military, and then those who are within the military who then become officers, the fall off is significant. I believe the numbers of African Americans now is about, I believe it's 17%, but they're probably at about 8% or so in terms of the officer ranks. And if you looked at those percentages for their white counterparts who are doing those same things, general population, percentage in the military, and percentage who are officers, excuse me, the percentage of their white counterparts who are in the military is far higher, but their percentage of those who are officers are even higher than their percentage in the military. So it's actually reverse of what you see. And so again, those are things that feed into these inequities in health and help generate that as a real problem for folks. Review of data provided by the Pentagon and the Department of Veteran Affairs shows us that Black service members are less likely to become officers and more likely to be seriously injured while serving their country than their white colleagues. And again, it just gets back to some of what I was talking about. And here are some of the slides that were a part of, or graphs, shall I say, that were a part of that conversation with Shulkin, where we talk about military veterans are becoming more diverse. Now, we've seen that happen from World War II to post 9/11, where you can look at the purple as being African American, orange is all other people of color, and then blue are Caucasian. And you can see when you look at post 9/11, you have 20% and 15%, so about 35% of people of color, if you will, versus 65% of Caucasians in the post 9/11 era. When we look at that officer piece that I was talking about, you can see that all enlisted service members, 19% are African American, 9% are officers, 13% of other people of color, 12% are officers. And then you can see their white counterparts is 67%, but 76% are officers. So again, when you're talking about the types of jobs one has, resulting in some of the types of injuries, illnesses, and diseases that they end up with as a result in relationship and association with the type of job they have, you can see why these inequities occur and are sustained. Black veterans more likely to sustain severe injuries. Again, this speaks to the types of jobs that I was talking about before, and then coming out and having service-connected disabilities. And you can see here, excuse me, service-connected disability rating of 70% plus. You have about 31% of Black veterans having a service disability rating of 70% or higher. And that's directly related to the type of work they do while enlisted in the military. So some of the other top injuries, wounds, and illnesses, obviously that we think about with the conflicts that have been going on since the global war on terror began. About 1 in 10 veterans experience any one or the combination of those that you see listed here. Iraq, Afghanistan war lung injury, I'm sure many of you give thought to that more so than civilian counterparts will. I know in talking with them, I oftentimes say, I'll bet you your next 2 paychecks. And I give them a scenario of someone coming in at the height of allergy season with shortness of breath, limited, ability to do daily activities of living, whereas they were fine with doing all these kinds of things before. They could or couldn't be a smoker. It really wouldn't have put that much change into the scenario I present to them. But I then say, I know for sure that Iraq-Afghanistan war lung injury would not be a part of their differential diagnosis. And we know that that would be true because there's no reason, rhyme or reason for them to think about that, particularly if they haven't ever asked that person if they're a veteran or had they served, because it just wouldn't cross their mind. Dismounted complex blast injuries. Obviously, you don't have to necessarily be right where the roadside bombs explode. You can be several feet away from that and still get the blast injuries. A lot of people obviously know about PTSD. Many do not or have not at least heard of the terminology post-traumatic osteoarthritis. CMI, sort of the new sort of definition of Gulf War syndrome, when they put specific symptoms in groupings and said that you must have them for a certain amount of time, then they more clearly defined Gulf War illness and called it chronic multi-symptom illness. Genital urinary trauma, we know we have a lot of that from those roadside bombs and people being right in the pathway of the explosion. Sleep disorders occurring across the board. A lot of it having to do with moral injury that's incurred and experienced by a lot of our service members while they're serving, and it spills right on over into their into the transition into veteran status. And again, not asking specific questions around that, we may not be led to that particular diagnosis of oral injury. And some of the other things are obviously more the types of illnesses that we're familiar with, like diabetes, cardiovascular disease, various cancers, et cetera, COPD, and those kinds of things. Mental and behavioral health conditions. Again, post-traumatic stress disorder is a big one. Most are aware of that and acknowledge the potential for it being there. Psychiatric illness after traumatic brain injury. We know that PTSD is strongly associated with a TBI, depending on whether it was mild or moderate. Depression and anxiety are 2 symptoms that are very significant, as well as plentiful, if you will, among the veteran population, in particular, as a result from any of the things that may have caused PTSD, TBIs, moral injury, as I mentioned before, also contributes to those. Some of the other mental and behavioral health conditions affiliated or associated with TBIs include the alteration in brain function that it has, surrounding thinking or memory and reasoning, sensation, which relates to more their sight and balance, their ability to communicate and express themselves, and emotion, whether or not there's personality changes. A lot of people talk about aggression and acting out. And then it can also cause epilepsy and put you at increased risk for Alzheimer's disease, as well as Parkinson's. So some of this we talk about as a vicious cycle, particularly when we talk about the mental health needs of veterans. And so if that's sitting at the center and we're not addressing those, and you have this bidirectional exchange from unmet mental health needs that can result in substance misuse, violence, trauma, incarceration, poverty, and homelessness. Again, you heard me mention that 40% of veterans are homeless on any given night, and then poor physical health surrounding diseases like diabetes, cancer, coronary arterial disease, et cetera. So this sort of brings us to where we are right now today. A crisis within a crisis within a crisis is COVID-19, if you will. We look at this veteran community that's especially vulnerable. And if you overlay that with race, you have significant additional health inequities. And this is why we get these sustained level of comorbidities. I put this quote here of a gentleman actually who was in the Bethesda area. There is a small community of amputees as a result of the type of warfare that we experienced in Iraq and Afghanistan. And so the way they have expressed getting through and surviving and thriving even has been around coming together with others like themselves, but actually going out and helping other people understand what this means, understand who they are, and that it doesn't limit them, understanding that you can still live your life, etc. But once COVID-19 hit, you see this quote here from this gentleman, Hamill. It says, "My own personal health has been reignited. This pandemic, although viral in nature, alludes to what happens to us as human beings when we are stripped of our outlets and deprived of our ability to socialize." He was one of 3 veterans who committed suicide within 4 months. All 3 were amputees. And so, again, as we talk about inequities in the ability to provide the type of healthcare that's needed, we're talking about the numbers of people who are dying from this virus are up to 450,000 plus. So the conversation around veterans and suicide, as well as other sorts of health concerns, you don't really hear a lot of discussion about it anymore because we're talking about, obviously, the overwhelming issues around COVID-19. But as a result of that, those suicides are increasing. One of the organizations here in Georgia, where I am, works with veterans who have PTSD, TBIs, et cetera. In fact, the gentleman who runs it and has run it for the past, I believe, 10, 12 years, has PTSD and TBI himself. His entire face has been reconstructed because of an injury he had in Iraq. But he says as long as he has been doing that, he has never had 2 of his veterans commit suicide in the same week and having 4 in the same month. So this virus, this COVID-19, this discussion about the pandemic is serious, and it sort of overwhelms the smaller news stories, if you will, around veterans and the care that they need to get in spite of what else is happening. And so we need to keep that in mind as you see veterans, even service, but veterans in particular, and their family members. And this just shows some of the cumulative cases as we talk about patient category and race and ethnicity and how many we've had over the course of time. And this is a couple of days ago, if you will, in terms of the numbers that you see there as active cases. This cutout was done, I believe, 2 days ago, and it's an active counter. It keeps up with it daily. And so analytics, insights into what we've been talking about here, looking at patient data to identify health and healthcare disparities among veterans and other populations that you serve. And so if we're talking about most of you, it would be veterans and those service members and their family members. The question is, do we ever look at any of that data? I know when I was in uniform and we were talking about healthcare disparities, folks were like, well, you don't have that in the military because you've got access to care. You don't have to worry about being able to pay to see a doctor. But while that is true, it doesn't necessarily mean that those issues don't prevail there. And so keeping a check on ourselves to making sure that we're not assuming things that we shouldn't, looking at the data could be extremely helpful in ensuring that we're providing the care that's needed by the community that we're serving. Intersectionality in practice means reflecting on how your health perceptions, your treatment decisions, perceptions of people and patients are influenced by your own identity. And so how you look at other folks that you provide care to. Developing the necessary skills to facilitate gaining trust of your patients, enabling them to reveal social identities during the clinical encounter. And while we might not think that that's a lot of that going on, again, in the environments in which you all operate, you might test that out a few times. As I talked about issues around moral injuries and what have you, there is a lot of that is not revealed to those who are providing healthcare if we're not asking. There's the issue of military sexual trauma, which is extremely prevalent in our service academies, on our ships, in our bases, at our posts. So asking or listening to what is being said may prompt you to ask a few more detailed questions and look at how you might get a little bit more deeper response that might help you better, again, assess what's going on with that patient who's in front of you. And then engaging in training and research and education that explores the impact of intersectionality on health as you continue to learn and see patients. And so that's our list of references. And any questions?
Thank you, Dr. Lewis. We have 13 minutes left. So any questions, if anybody wants to ask, you can speak or you can put in the chat box.
Dr. Lewis, I'm just curious your thoughts on bringing this kind of topic to undergraduate medical education setting. When do you think those learners are best ready to take this information and actually internalize it?
Well, thank you for that question. I think they're always ready. I think it should be done at the very beginning. And the reason I say that is this is longitudinal learning. It's not something that, we insert in a course or a block of this or this rotation, if you will. This is something that, again, runs longitudinal through the work that we do with our patients. If they don't learn this until, if we don't put this into a block in the third year, what happens to all of the folks they're interacting with in the first and second years? So I think it should be looked at as a piece that needs to blanket all of our education in terms of understanding who our patients are. Does that help you any?
Yeah, certainly. I think the challenge is when there isn't necessarily a person responsible for that overarching. I mean, there are, and I think we have some good steps in the right direction for this, but it's a challenge when things are compartmentalized.
Yeah.
How you provide that in a consistent way.
Yeah, I agree with you. I remember when I was at USU and the LCME had just come up with this requirement to teach cultural competency. And so I was there and I worked with another colleague, Richard Tannenbaum, out of the Department of Medical and Clinical Psychology. And so it was clear that we needed something in the curriculum around cultural competency. And we spoke with the dean about it, and he was thrilled that we were willing to do this and highly encouraged us to. But he just said, just do it without increasing any time in the curriculum. And so that became very interesting. Obviously, you know, the curriculum there at USUS is already very dense, but I sort of pictured that as a block of Swiss cheese. And as we know, Swiss cheese has holes in it here, there, and where have you. And so I thought about, how do we take cultural competency, the construct, and weave it in between those open spaces in that block of college cheese, which meant to me, how do we figure out, how do we integrate this construct in and throughout the curriculum across the 4 years without adding additional time. And so it wasn't totally without adding additional time, but it certainly passed the test. And you do that because it has to be a part of what you're doing, a part of how you teach and what you say, and in all of that coming from the leadership. All of this stems from those of us who are teaching them. Obviously, we learn from our students too, but while we're teaching, if we're saying this is what you need to be doing for your patients, then we need to be doing that with our patients. And if we're doing it with our patients, when they're seeing us, when they're interacting with us, when they're talking with us, they're seeing us doing what we're telling them they need to learn. And so it is that individual responsibility to a certain extent, but for those who are in charge of courses or rotations or what have you, they can still be held to some level of accountability for ensuring that this kind of information is longitudinally woven through what they are responsible for.
I'll jump in with a question if it's okay. Hi, Dr.
Sure.
Lewis.
Hi, how are you?
Good. I was at USU when you were there as faculty,
Yes.
so it's great to see you again.
Thank you.
I'm curious, your last couple of slides when you were talking about kind of the ability to engage with the social identities with our patients. And, you know, I would say probably even as educators, we're doing that as well. What are some of your, and this is probably something you do so naturally that you may not even like you'd be able to say it exactly, but what would you say are some of your preferred ways of engaging those, you know, again, whether you call it a technique or a skill set, when you're trying to engage with social identities with patients and students, what do you use? What are your preferred approaches?
Well, it's for me right now, it's primarily a conversation, a dialogue. I try, and I don't know if it came through here, but I try not to present to people so that it's this one-way transmission where I'm just pushing stuff out. It needs to be more of a conversation or dialogue as you talk about or speak to these issues. And now, of course, since leaving USUS up to now, you know, in working in this area, I've encountered all kinds of veterans and service members and family members. And so I have a lot of stories that I can bring forward as I'm talking about things. So if I'm going to talk to you about, you know, access to care, and, you know, if you're providing that, I'm going to say, well, you know, what kind of care are you giving them? Your military, yes, they don't have to, you know, fight for appointments and, you know, all that kind of thing. And we may not be as constricted with the amount of time you can spend with them, but what are you doing for them while they're there? Okay. Just because you can give them 20 minutes and this guy over here can't give them but 10, doesn't mean they're getting better care. So providing that kind of conversation and interaction with them while we're doing it.
This is Diane Cyberden with the Graduate School of Nursing. Thank you for your talks. Very interesting. I'm thinking about our curriculum in the simulation environment, because to me it seems like that's a very rich place. We can keep our standard case, but we can weave in some of these constructs in a real world, so they have to deal with it. We're not telling them how to do it. We're exposing them to the experience and having them do it themselves. And when you said you had lots of stories, I bet many of them would be really easy to transform into a simulation, sort of into a script, you know, to weave them into some of our stories. So anyway, I just thought that might be something long-term that we could do, take some of your life lessons and bring them to the sim.
Yeah, I think that that's a very good thought, actually. because it allows for some standardization of what's occurring. Yeah, that might indeed be a good way to look at how this could be woven into the training. Agree with you.
Good afternoon, Dr. Lewis. Thank you for your talk. I was wondering, is there any, you made a really good point that the access doesn't mean good care. Is there evidence that basically shows that we are reducing veterans' engagement by telling them to suck it up when they get hurt in active duty, by giving out more Motrin and more, you'll get better, just believe me, and blowing off people's concerns?
I would venture to say yes, and I bet you could find it fairly easily. I did a session yesterday. I run this foundation, the Veterans Health and Wellness Foundation, and we do an event once a month that's called Veterans Lived Experiences. And I have veteran guests on there who are talking about whatever the topic is. And so yesterday was MST, military sexual trauma. And we had three guests, all were female, and they were talking about their different experiences with this. And one of them in particular spoke about going to see a psychologist about this. And she wasn't even physically assaulted. Hers was around the sexual harassment, the innuendos and all of that sort of thing. And as a young person, it was, extremely intimidating, et cetera. And so she finally got to go and see a psychologist. And she said she left with 5 prescriptions. 5 prescriptions. And she's like, okay, so now what? So she still had what she went in there with, and she wondered why she had 5 bottles of medicine to take that didn't seem to her to connect with what was going on. 1 for sleep, 1 for depression, 1 for this. And so that's what I mean. I mean, access to care means that we have to provide that when they come to see us.
And not just transactional.
Exactly.
Thank you.
Mm-hmm.
Ma'am, this is Dana Nguyen. I wanted to say thank you on behalf of the Department of Family Medicine. I also was a student at USU when you were faculty.
Yes.
And I am humbled and amazed by, sort of hearing your story about trying to integrate some of this education into the USU curriculum. This was 20 years ago. And I would fancy to say that Dr. Frankie Cimino here, who has faced some of the exact same battles within the last year on the Executive Curriculum Committee, trying to integrate these topics. How do we convince our leaders that these topics really need to be addressed as the foundation of our medical education and not just plugging holes or plugging important things into holes where we have a hole?
I think we perhaps need to get you guys some of this information so that presentation can be done for them, so that they can actually hear and see the connections. It's easier when you're up here and you know all of what has to get covered, and so you say we don't have time for this, we don't have time for that. But if you don't have time for the kinds of things that we're talking about today, you're going to have many more issues down the line. As they say, you can pay me now or you can pay me later. And we saw the information from how when folks have certain types of jobs and they're doing this, that, and the other, they come out and they have higher percentages of service-connected disabilities, and their life is impacted for the remainder of the time that they're on Earth because of these things that were done here. If you remember when I talked about social determinants of health, I said there's about 20% of that is due to clinical care. So that's us. Okay, that's what we're responsible for. We can't really do much perhaps about where they grew up and their experiences there, but when they come to us for clinical care, that's on us. And so we have to be ready for that. We have to educate ourselves, we have to train ourselves, we have to be ready for it. And just because we're in uniform And just because we're this or just because we're that doesn't mean we get to skip that grade. Okay? We still have to make sure that that happens. Okay? And so you could translate that into, you know, when we do all of our training, because we are military and we're training them to be military docs and officers first and all of this. Well, would you not give this type of training to your officer? Would you send them out to lead your troops without providing this, or just trying to plug it in down the line? If you wouldn't do that, then you can't do it this way either. Okay, because regardless of how well trained that officer is, if he's not healthy, and if he doesn't understand that his not knowing can impact the health of his troops, then again, he's not going to pay us now, but we're going to have to pay dearly later. So providing this same kind of conversation to the leadership and perhaps translating it into the language that they speak might be a little bit more convincing for them. Sometimes I tell people, well, you know, if you're not going to do this, why do we give soldiers bullets when they're going to war? If you're not going to send them out armed, then what are we looking to accomplish here? So sometimes we have to, you know, speak it a little bit differently to have them think about it a little bit more. Because it's much better for us to win these battles here, because if we do, then we can ultimately win the war.
Yes, ma'am. Thank you.
Sure.
Well, thank you. I think we are out of time. Thank you, Dr. Lewis, for very interesting and intriguing presentation, and for everyone who participated. We will have the recording out to you when we have it ready. And again, please do evaluation and claim your CME credits. So we're gonna end here. I'll stay on for a minute or so in case there is any other last minute.
Sure. And if you guys think of any other questions or think that I could help you get some information or what have you, feel free to give me a shout.
Thanks so much for joining us, ma'am. We really appreciate it.
You're welcome. Thank you for the invite. You all take care. Stay healthy. Be safe.
Yes, ma'am.
All right. Take care. Bye-bye.
Thank you. Same to you.
Bye-bye.
Very much.
Bye-bye.